to getting that sort of information. We could call that content, They're reporting about facts or their own observation about their experience. We're also doing something else. We're observing their behavior, kind of broadly defined. How are they in the room? We can call that process, perhaps. What do they look like? Are they well dressed, groomed, or are they disheveled? Are they speaking kind of in a tone within normal limits? Or are they, very animated and agitated?
Right. Overall appearance, how the person conducts themselves, how the back and forth goes in the conversation, rate, tone of speech. So not just what they're saying, but how they're saying it. This is part of what we term the mental status exam, or a mini mental, that can at times influence or inform the diagnostic process.
Right. For example, if someone is, in a manic or hypomanic state, that's going to be manifest by both potentially the rate of speech, their body language, and also are they able to speak in a kind of logical, sequential manner, or are their ideas kind of flowing all over the place and not really making sense?
Absolutely, which again is part of some diagnostic categories, or is something of note, that it is remarkable within the clinical environment, that ironically we almost would hope to be unremarkable clinically. It's one of those moments in life where you hope to be unremarkable because we are in essence remarking upon the person's behavior.
Yeah.
That it is something we didn't expect or seems to diverge from that normal limits. I'm hesitant to use the word normal, but the normal limits, the boundaries around conversation and behavior that occur between two people.
Right. And you're also looking at things like affect, or, which
Right.
again, there's a real difference of saying, you ask them how they are and they say, oh, I'm fine, versus I'm fine.
So in that case, your mood, I would code as or write down as I'm fine. But your affect, what I can see about your demeanor, your visage, your presence is not congruent with your report.
Hmm.
So affect is what I can see, mood is what the person reports.
Hmm.
So you're assessing the match or mismatch between a person's reported mood and their observed affect.
Hmm. Are they able to maintain some form of eye contact with you?
Sure, which, to reach back to the cultural discussion, that can be a hard one to define. What is appropriate eye contact? What is inappropriate? What is enough but not too much? And so that's kind of that mixture of art and science and our own experience in the world and the context of the counseling relationship.
Right. Sure. Some people in some cultures, it might be considered deferential not to have a lot of eye contact.
Mhm. Or inappropriate or rude to stare somebody down eye to eye for extended periods.
Right. But just to use kind of an extreme example, if someone came in, picked up their chair, turned it uh, so their back was towards you the whole interview, you'd want to make note of that.
We would make note of that, right?
Right.
But you'd have to consider that within its relationship to the rest of the interview.
Mhm.
Nothing can exist on its own within all these topics we've been covering around assessment. That it is part of forming a more holistic clinical picture. That no one piece of information is definitional, that it's about the overall combination, the picture that is formed.
Right. And a lot of that is going to depend on what the context of the interview is. Are they coming in, voluntarily for counseling or therapy? Are they coming in involuntarily for counseling or therapy? Or are they coming in because for legal reasons? You're hired by the state to do a forensic evaluation because of some behavior they've committed.
Absolutely, that is an essential part of knowing what we're doing and what order we're going to go in. We
Mhm.
really try not to just use a scripted, this is the order we go in when we're doing a semi-structured general assessment. That we meet the person where they are, with the issues or problems or statements that they bring in. For example, if someone tells you they're suicidal, and says, I've been having repeated thoughts of harming myself, I think about it this way and it occurs pretty frequently, that's going to change the route of my assessment. So we have to be kind of ready to call an audible, to, in our own heads, reprioritize where we go in an interview.
And if, for example, if you only had a limited amount of time in your schedule to see them, you're going to focus on, further assessing the suicidality, managing that if there's some steps that need to be made. That's more important than completing the full diagnosis.
Absolutely. That this is a journey, not a destination. And so the important part is that the journey makes sense, in terms of what's clinically relevant, what is potentially serious or dangerous or harmful, and be ready to reorder and kind of drop the agenda at points.
Yeah. Now, barring some kind of emergency like that, your goal is to get some sort of diagnosis or not. But that will still vary depending on the context of the interview. Is it to prepare them for counseling versus, to decide whether they are eligible for disability benefits?
Absolutely. And within that, we also have to acknowledge the role of rapport, of relationship. Um, because often this will be the person we see in counseling. And if we're strictly sitting there with a clipboard, asking question after question, what does that do to the relationship? How does that affect it? So while we are assessing and observing, we're also monitoring how it's going. How is the space between us?
Right. And that's one of the real arts, one could say, of becoming a good clinician in general, but certainly a good diagnostic interviewer,
Sure.
is balancing your need to get certain information from them for whatever the purpose is, whether you're seeing them in private practice and you want to make sure you're covering the bases, or whether that's part of your job requirement and expectation by your superiors that after a single interview you have to fill out some paperwork and check some boxes.
Sure.
You need to learn how to manage that process to meet whatever goals you have, with the process of establishing as good a possible working relationship with your client.
Right. So it takes a lot of practice. I think sometimes that's why we call it a clinical practice. That my most valuable lessons have been when I've made mistakes, when I've made errors in this process.
Mm.
That gets us better. And this takes a fair amount of time to get comfortable.
Mhm.
And then there's always the situation where the next person who comes in, um, presents a situation you've never seen,
Mhm.
or a situation where you're um, feeling off balance yourself. And so we get better through that.
Mhm.
It's not something we do right the first time by any
Mhm.
means.
Mhm. So there are certain guidelines and certain pointers you'll be giving out, but you know what you're saying, which is should come as no surprise, is that this is an ongoing learning process.
Absolutely.
Now let's move on to presenting symptoms or complaints. What brings the client into the office? Sometimes we'll see in the first clip coming ahead, they're self-referred. And then in the next clip, we'll see an example where the client is referred by, in this case, by his partner. Oftentimes they may be referred by a family member or significant other.
So, Christine, let's get a little more specific. Can you tell me a little more about what's bringing you in for counseling today?
I had some inexplicable events occur in my life. I've been dealing with it alone. I haven't discussed it with my husband yet. I thought I'd come here to get a professional opinion.
It's really nice to meet you. Tell me what brings you in today.
Well, she brings me in. I I feel that there's some issues that I feel just need to be addressed. He doesn't want to be here, but I just feel that um, there's some things going on within himself, and it's troubling his life. I feel with his work and our relationship, um, he is battling within himself um, some stress. We did have an accident, and that's just something that we're still dealing with, and he is also still dealing with.
So we take note of the reason for referral and also the source of the referral. Self-referred, referred by a family member, a friend, or sometimes even the courts.
Hmm. And it's just something to keep in mind. You'll see whether that really plays into the assessment or treatment or not. Sometimes once they come there, they're cooperative. Other times, not so much.
Sure, sometimes that may become relevant as the relationship develops, as the kind of clinical conceptualization develops. Other times it may not be. But we gather the information anyway. We want to pay attention to that just in case.
All right. So once they're in your office, what are you looking for in terms of presenting complaints, severity of symptoms, etc.?
So, first of all, I think it's important to note that it is fairly common, it's not uncommon, for people to be vague at first, or standoffish, or have a hard time reporting the details that we may be looking for, or be able to respond to the questions that we pose. It's intimidating. Um, Here's a person asking all of these questions, maybe using terminology that's not quite familiar, and it's natural, it's expected for people to be a bit standoffish, to take their time warming up, and for the clinician to have to find that balance between gathering information and creating relationship.
Right. I mean, uh, we're asking them very intimate things that they may not have talked to anyone about before.
Absolutely. We want to ease a person in, comfortable environment, conversational tone, but at the same time, we do need to gather the information, and we need to get some sort of, um, like we said before, a holistic picture of what's going on, how often, how much. So that back and forth between probing and listening.
Right. And so then, how do you kind of fine tune it if someone is able to tell you that they're experiencing some anxiety or they're stressed about something? What are you thinking? What kind of questions are you asking to try to clarify the nature of what they're experiencing?
So, how do they define that term? If
Mhm.
somebody says, I had a panic attack, or I freaked out the other day, or whatever language the person uses, whatever terminology or slang or anything they use, I want to say, what do you mean by that? And what does a panic disorder or panic attack mean to you? What does freaking out mean?
Mhm.
What does depressed mean? Tell me more about that. That's what we call concretizing,
Mhm.
to make sure that I'm not jumping to conclusions as a clinician
Mhm.
with the terminology the person is using. We don't make assumptions.
Mhm.
We check in. We check back.
Mhm. So if someone's freaking out, does that mean they just cried for a few minutes, or did they start throwing things around their house?
Exactly. So, what particularly was the kind of objective part of that? Tell me more about what you mean by freaking out.
Hmm. And so that requires that you often ask a lot of very specific follow-up questions.
Absolutely.
Hmm. You want to know kind of what their subjective level of distress is.
Sure. I think we use the term distress a lot, but everybody may experience that differently. So sometimes it takes kind of honing in on that. So maybe using a brief attempt at an objective measure of that. So if I said on a scale of 1 to 10, one being not distressed at all, 10 being the worst distress you've ever experienced, where would you say you fall
Yeah.
within that scale? Which we can follow up on in later sessions to see how things change for that person's experience.
Right. And that's sometimes, often what they'll tell us seems consistent with what we're observing and the kind of language they've used up to that point. They seem very distressed and they say a 7. Other times they may seem pretty calm and blasé about it, and yet they tell you it's a 9. So that can give you some useful information.
Mhm.
Uh,
Absolutely.
and you also want to know kind of what precipitants there were.
Yes, we always want to explore, did something occur? Was there an event that seemed to lead into or was a precursor towards this change in functioning, change in emotional experience, etc.? And sometimes the answer is no, nothing happened. This just seems to be the way things rolled out. Or on occasion, it is, yeah, after this event, after I lost my job, after my mom passed away, or I moved, or all the sorts of life stressors, was there a significant change in the person's functioning or experience?
Right, and that certainly tells you useful information, both in terms of understanding them and also, diagnostically. Is this an adjustment disorder or is this
Mhm.
something totally different?
Yes.
All right. Okay, let's take a look at your interview with Kathy. We're going to jump into it a couple minutes into the interview after she's reported that she was laid off from her job just a couple months ago.
All right.
I'm really the type of person that I bounce back from things pretty quickly, easily, can, move on with life and try to keep going. But for whatever reason, this has just been awful. And I'm just so sad. The feelings of sadness are just overwhelming. And I just can't find a way to do that, to move on or to do the things that I know I should be doing.
Hmm.
So it really hit me a lot harder than I ever thought it would.
Hmm.
So.
And prior to losing your job, or in the past, have you ever had a period of time like this before?
Not really, no. But I mean, honestly, this is probably one of the worst things that's ever happened to me. I was always a good student. I
Mhm.
kind of knew what career I wanted. I'm really close to my grandmother, and she's always been real helpful.
Mhm.
So this was the first really, I would say, life-altering thing
Okay.
that has happened. So,
And it was about 2 months ago, you said. So
yeah.
in these 2 months, let's think back. How many days out of a week would you say that you're dealing with these types of feelings?
I would say pretty much every day.
You seem to be forming at least a tentative hypothesis about the depressive symptoms she's experiencing and the loss of her job a couple months ago.
Right, but it's also important to clarify and to realize that um, the job loss happened in this case, but she could have been feeling depressed or report depression or feeling blue prior to that. So it's part of that figuring out the timing of how things played out. The job loss could have added on to it, but we need to know if this was a set of experiences or symptoms that she's been experiencing for a very long time prior to the stressor, or if this occurred just in a kind of discrete fashion in relationship to the stressor.
She did indicate she was quite emotionally distraught, or in DSM parlance, experiencing significant emotional distress.
Right. It's part of that subjectivity in the assessment of mental disorder that we discussed earlier. How do we know if somebody is significantly distressed? And for Kathy, her statement that this may be one of the worst things that's ever happened in my life clearly to me indicates that this is clinically significant for her.
Sometimes when you ask clients questions, they give you rather vague answers, at least at first, and you need to push them a little bit to, get a clearer answer from them. Let's take a look at a clip with your colleague, Pauline Lucero, interviewing a woman who appears to be depressed.
Sounds like you've had a lot of trouble sleeping lately. How long has that gone on for, Michael?
A few months now.
What's a few months to you? Is it 2? Is it 5?
I don't know. About 3 months, I would say.
in order to make a diagnosis, you need clear, specific information a lot of the time to check it against the criteria, et cetera. And if a person is having a hard time being specific, that does mean sometimes we need to probe a little more, come at it from a different angle, with again that balance between being too pushy versus not getting enough information.
Hmm. Sometimes you just need to kind of come at it from a different angle, ask them the same question again. Let's look at another clip with you working with Kimberly.
And so then you said you were sleeping about 12 hours during the course of a 24-hour period. How has that been over the last couple of years? Has that changed?
Not really.
Not really. So you're saying it's kind of been the same throughout the last couple of years, maybe even beyond that. That about 12 hours. So no real change in that.
Yeah.
So then you sleep about 12 hours, and when you wake up, how is your energy?
I don't usually have a lot of energy.
Okay. And are you still feeling tired when you wake up?
Mm-hmm.
Yeah.
I'd say so.
Okay. And then you go to work, and how is your energy at work?
Let's say my energy is always pretty low.
Always pretty low.
Yeah.
Okay. So then after work, and how many hours a week do you work?
Probably about 30 or so.
About 30 or so. And so then you get off shift,
Mm-hmm.
and what do you do then? What's a typical day for you?
I just go back home and, I'll sit around the house for a little bit and then I'll just go to bed.
Okay. Is there any time that's different? Time you go out with friends or do something more recreational?
No, I don't have any friends.
No friends that you can talk about? Okay.
It appears she's so depressed that there's just kind of not a natural give and take that you often experience with clients or just in any conversations. And that can feel a little awkward for therapists to have to kind of keep pushing forward without that give and take.
Absolutely. As clinicians, we're trained primarily in doing therapy and forming that relationship. And as we've spoken about, assessment is different. It requires a give and take. It requires asking questions, probing, coming from different angles, etc. And that can be quite uncomfortable for the therapist and for the individual seeking help from us. And I know in my experience, there are times where in the back of my head, I'm going, I have to get the information. I need to arrive at a diagnosis, especially at certain clinics where you're required to come up with something by the end of the session.
Mm-hmm. So you can feel some pressure from that.
Yeah, especially in the early times of doing assessment, the first few times where you really feel like you have to produce a product and you need to do this right. And so as you do more and more, it can become easier to, as we may do in counseling a lot, just kind of tolerate the silence. That in itself provides data. How long a person may take to respond to a question, the amount or quality of their speech when they do respond. Going back to the mental status aspect, those give us data around rate, tone, volume of speech, all of that while a person may not speak a lot, their lack of speaking is also potentially diagnostic. In Kimberly's case, just the general paucity of speech, which means kind of the lack of speech, that single syllable responses, the delay between when I ask a question and when she responds, the monotone quality to her voice, combined with the overall affect of her face. So even saying she's sad, that seemed congruent with her facial expression.
Okay.
So all of that kind of combined together can help to build the diagnostic picture.
Okay. Well, that's a great example of kind of the thinking that's going on behind the scenes of what you're hearing from her and what you're observing, and you're integrating that and you're taking that into account, as you complete the interview. So we've talked about kind of distress. That's one of the hallmark features of a disorder. And the other one is a disability in social or occupational or other functioning. Um, and where the person may or may not feel that they have a problem, but there's some indication that there's some level of impairment.
That's correct. We're looking for impairment or decline or significant change in functioning in occupational, social, recreational, educational status,
Mhm.
or the ability to perform
Mhm.
in a certain context. And then, in addition to that, in tandem, has there been a change?
Mhm.
What was the functioning like prior to the onset of symptoms, if the person can recall, if that's something they're willing to talk about. And then did that change post onset?
Mhm. All right. And sometimes you have to be a little strategic about it because if they, I mean, if they're sad or distressed, they'll usually be able to report that. But if the problem seems to be in their behavior, they may not be aware of it, or they may be kind of resistant to uh, acknowledging that.
Absolutely. And that's one of those cases where it's a little push pull. I want to ask some questions, maybe come from a different direction, try again. But it's also something where we can wait and see. We can get some baseline data
Mhm.
right now, and then as the relationship develops, perhaps we fill in some of the blanks on
Mhm.
those.
Or maybe you ask some kind of indirect questions like, you know, your wife wanted you to come here. Why? What would she say? You know,
Correct.
what's
So
concerning her?
things like, has anybody else noticed anything or mentioned anything to you? What do other people in your life say about this? Which both makes it a little more distant, perhaps a little more comfortable to talk about, but also can serve the purpose of getting closer to that information.
Okay, so we're going to see an example of that in your interview with Jeb.
Great. So you said you're not quite sure why you're here, but let's give it a guess. What do you think's bringing you in today?
Well, some friends just kind of, jabbing at me and telling me I'm just not my old self, and things going on, and I've been late to work a few times, and that hasn't worked out really good. Usually I'm right there and ready to rock and roll, but moving a little slow lately.
Okay. So your friends have been saying, "Hey, what's up? You're not your usual self. Maybe being late to work, not feeling like your old self." Anything else that they've mentioned along the way?
Well, bartender keeps taking my keys away.
Okay.
I have to find a way home. It's been expensive. But,
So the bartender keeps taking your keys away.
yeah, Josie keeps taking my keys away. Yeah.
This is somebody that you know
Yeah.
where you spend
Yeah.
time?
Yeah.
Okay. And what might be the reason that she's taking your keys away?
Well, she's thinking I'm drinking too much, but I don't think I am. You know, no more than usual.
No more than usual. So do you mind if we talk about that a little bit?
Okay.
Okay. So let's just talk about the general pattern. How many nights a week do you have a drink of some sort?
He's not convinced at all that he has a drinking problem, but there's certainly some evidence that his level of alcohol consumption is problematic.
Correct. He seems pretty clear that he's not experiencing a lot of distress
Mhm.
about this, to use the DSM terminology. But there does seem to be some mounting evidence of impairment.
Mm.
The views of other people in his life, the effect on his behavior and relationships. So that's a pretty delicate balance of gathering information without directly contradicting or offending or um, arguing with the individual.
Right. You you don't try to convince him, that he has an alcohol problem, that he's in denial, but you do push forward with asking questions, and getting some information. Another piece of data is that the bartender, is holding onto his keys and not letting him drive home. Now that's a pretty strong evidence, she would not be likely to do that unless he was, visibly intoxicated.
Correct, and we're making somewhat of an assumption there. But we'll again, this isn't a one-time deal. We're going to develop this over time. This is the best we can do during the first information gathering session, and so it starts to build a picture that we're going to continue to check in on.
You didn't really challenge him directly on whether he had a drinking problem or not. You didn't try and convince him, that he did, or that he was in denial or anything like that.
Correct. It is that fine balance, as we spoke about earlier. Um, Before the interview even starts, before the assessment starts, we talk about how the person does not have to speak about topics or answer questions that they don't want to answer. So, trying to empower the person, give them a sense of, um, the ability to draw a line during the assessment session. But that's also balanced with my own need to gather information, um, and to make use of the time we're spending together in assessment. So those two things together can often get confusing, get frustrating, but it is part of the unknown nature of what we're going to get when we walk into an assessment session.
Right. So you did ask a number of follow-up questions to get some information about, about how he's been doing, and he revealed some information to you about the bartender taking away his keys, and that certainly provides some pretty compelling evidence that there's probably some problem there. She wouldn't likely do that unless he was visibly intoxicated.
Correct. And I found over the years that the little voice in the back of my head that may want to say something confrontational or direct to a person coming in for assessment, such as, hey, it sounds like you have a problem with alcohol. Well, it is likely that somebody else in that person's life has said that or acted that way. So that is a nice technique to say, I'm wondering if anybody in your life has mentioned drinking as a potential problem for you.
Uh-huh.
So it removes it from our relationship. It retains our ability to relate most times, but still arrives maybe at the same destination.
Uh-huh. So that's kind of another trick of the trade.
Sure. Yeah, one of the pearls.
Right. Let's take a look at another example where the client is not at all on board with the idea that there's something wrong with her, that she has a problem.
Okay.
Do you think you're at a good weight now, or do you think that should be different?
I mean, I don't really know. I mean, it's what I weigh myself, and it's like after, being on a certain diet, it's like I can see what if I just lose a few more pounds, sort of. And I mean, I don't really think you can ever be too thin. So.
Mm-hmm. So, at your current weight right now, how much have you lost, let's say, in the last 2 or 3 months? Or have you been about the same?
I just kind of 3 months, maybe like 15 pounds, maybe.
And I'm wondering if that's what your doctor is concerned about, and your mom. Because that's a lot of weight to lose on your frame. Do you know what a BMI is?
Yeah.
And so what have they said your BMI is?
They said 16.
Mm-hmm. So that's pretty low.
I mean, I have a dancer's body.
So going back to the DSM definition of mental disorder, where there's either distress or impairment or disability, she's not distressed. She came in this setting because her mother and her doctor encouraged her to come, but she thinks she's fine. But she does report a BMI of 16, which, when we look that up, that's quite underweight, possibly malnourished, so possibly dangerous medically. So certainly there's some impairment in her functioning.
Right, that's spoken to in that diagnosis itself. The BMI or body mass index rating that we see from her is concerning,
Right.
and both goes towards the diagnosis, but then speaks towards some level of impairment, medical impairment, or at the very least, something to speak about with her physician.
So what are some particular challenges and maybe some strategies for completing an assessment with someone who is not distressed, but does have some indications of impairment or disability that
So in my own experience, perhaps this is most prevalent when somebody comes in for a court-ordered counseling, say for driving under the influence charge, and their statements may be something to the effect of, "I don't have a problem. That's their problem."
Mhm.
So instead of directly confronting that, which we may do in later sessions, once an alliance is formed, during these initial assessment periods, I may say something to the effect of, I'm not saying whether or not you have a problem with alcohol, but maybe we can agree that we've got a legal problem right now, and perhaps I can help you with that."
Mhm.
Um, and again, to plant the seeds and grow some roots of the therapeutic alliance, that perhaps later on, as the weeks go by and we're working together more, I might be more direct
Mhm.
about that. "Well, from what you've told me over the last few weeks, let's compare this to some of the diagnostic criteria and really use that as a tool."
All right. So you tend to play it cautiously at first, weighing what kind of rapport you have with them in determining how directly you might want to challenge them.
Correct. If the goal is to assist this person, well, we need them to come back and to engage in counseling. So I may do a little more pushing to see how intense the resistance might be, to use a more psychodynamic term. But once that's done, the goal is gather as much information as we can without ending the relationship prematurely.
Right. Especially if it's in a therapeutic setting. And we know that's a big problem is people don't come back often. So
Correct.
if you're in a setting where they're coming to get some help, if you don't get them to come back, your odds of being able to help them are pretty minimal.
That's right.